Today we are going to discuss regarding the iron deficiency anemia. So the iron is Fe2, Fe plus 2. Iron has two forms, functional form and the storage form. So functional form is a hemoglobin, myoglobin, and enzyme. And there is in the enzyme there is cytochromes and the catalase are the iron of the functional form. For the storage form there is a ferritin. Two-thirds of the iron stored in the ferritin form, and this is a storage form. It is a soluble form, and also another form is the hemocytin. Hemocytin is one third is aggregated ferritin composed or and aggregate and form the hemocytin. It is a non-soluble form, insoluble form. And when we look in the light microscopy with the fluorescent blue stain, it is seen, and electron microscopy only seen the ferritin. So regarding the iron deficiency anemia, so when we take the animal product, there is a heme form iron, and it is absorbed better 10 to 20%. But vegetable, fruits, there is inorganic irons, and it is absorbed 1 to 2% only. So most preferred for iron is called to iron for there is the animal source, animal meats. So when we eat animal meats or the fruits, it's the iron form going to the stomach. When come into the stomach, there is like something that inhibit the absorption of the iron by the like tannates, tea, carbonates, and the oxalate and the phosphates. This product inhibit the absorption of the iron, and also there is something that stimulate the absorption of iron, like ascorbic acid, citric acid, amino acid, and sugar. These are help to the absorption of the iron. So iron is absorbed only in the plus 2 form. So when it's come into plus 3 form, and plus 2 form direct absorbed, and also there is a ferrous reductase, which cytochrome B6 reductase that help to the like convert F3 to the F2, and F2 after that there is a divalent matter transporter DMT1 that help to the like absorption of the iron. And when iron is absorbed, so we have a beautiful organ, liver synthesis the like apoferroprotein, and also apoferroprotein from the plasma cell. So this apoferrotin protein into the mucosa, and it has the in the mucosa, after the absorption it bind with the iron and form the ferritin, and it is the storage form of iron. And after that there is a ferroprotein channel, and from the ferroprotein channel this iron passes through the in the plasma. So before going to plasma, there is a hepcidin receptor which convert F2 iron into the F3 iron, and F3 iron going to plasma, and plasma bind. There is a transferrin bind transferrin. It is secreted from the liver, and liver secretes transferrin, and transferrin is a transporter for the iron. Iron in the plasma, iron binded with the transferrin, and when the iron binded transferrin, it's go into the bone marrow. When it go into bone marrow, there is a clathrin, and also transferrin receptor. Transferrin bind, and there is a transferrin bind, and there is a endocytosis occur, and iron go inside the bone marrow cells, and there is a release of the iron and go into the bind with the hem form of the hem, and there is already synthesis of like from the succinyl CoA, and glycerin from the ALA, and ALA from the porphyrin, and porphyrin pyrrole ring from the protoporphyrin, and there is a iron binding, and converted into the hem bind with the globin, and conversion of the globin is binding with the globin, and the hem is converted into hemoglobin, and this hemoglobin go into the RBC, and this RBC release in the circulation again, and this RBC circulation, it has like 120 days of the survival, after survive in 120 days in the and they done of their function of the RBC function we discuss in later. So RBC after the 120 day, it's go into the macrophages, go into the spleen, and there is a spleen has the macrophage, and that macrophage capture the ruptured RBC or the after the death of the RBC, and this RBC broken down into the membrane, cytoplasmic protein, and the hemoglobin. So this hemoglobin broken down into the heme and globin. Globin is an amino acid, so it's converted into amino acid and go into the further product synthesis. But this membrane is also protein and lipid, so membrane protein converted into amino acid and lipid converted into fatty acid. But the cytoplasmic protein, this is a protein, so it's converted into amino acid, the smallest product of the compounds. And the main function go on the main product like heme is converted into the iron and the biliverdin. So this iron again in the macrophage there is a production of the apoferritin, and apoferritin bind to the iron and convert into ferritin storage form. And this ferritin again taken from the transferrin in the go to into circulation, or also it combine and form the hemosiderin. So now we have completed the iron how will go to the iron. And again this is a recovery of iron. So if a person have the bleeding disorder or GI bleeding, or there is there is menorrhea, or there is period menstruation cycle, so there is loss of blood, loss of RBC. When RBC is lost, so there is iron also lost, so this iron lead to the iron deficiency, so there is no storage form. So in the extravascular, or there is if the extravascular or in the spleen there is rupture of the RBC, there is a formation, there is a maintaining of the RBC storage. So ferritin is storage from the RBC. Regarding the biliverdin, so when we look the jaundice case, regarding the biliverdin converted into bilirubin and go into the circulation. In the circulation there is albumin, there is a albumin or bilirubin binding protein. Bilirubin binding protein bind to the bilirubin, and this bilirubin go into the liver again, and this bilirubin go into the liver and bilirubin, and there is a glucuronide transferase enzyme which convert into the unconjugated bilirubin. This is the unconjugated bilirubin converted into conjugated bilirubin, and this conjugated bilirubin go into the intestine, and small intestine there is a formation of this conjugated bilirubin into the stercobilin, and this stercobilin go throughout the phases of the yellow color. Also there is a reabsorption from the reabsorption in the liver and go into the circulation and go into the urine formation. So the urine is the yellow in color. So this is regarding the how there is a bilirubin metabolism occur. So I am not going to explain regarding this. I just briefly overview. After that, this is how iron synthesis, how iron storage, how iron is metabolized in our circulation, our inner body, and how there is a function of liver also secrete hepcidin. Hepatocytes secrete hepcidin. Hepcidin block the channel. This channel is known as this channel is a ferroportin channel. It's blocked by the hepcidin. If hepcidin block this, then there is a deficiency of iron. Iron does not passes through this transporter, only store and does not passes. After that, loss of iron. If 1 mg per day in the male and female 1.5 mg per day. So through the male, in the male there is a throughout the feces, urine and the sweat. But in the female there is a menstruation. So every menstruation there is 30 to 50 ml of the blood loss. So there is a lot of the iron is lost, and also feces, urine and sweat. And if we look at the transferring iron binding capacity of the 300 microgram per deciliter, and a transferring saturation is 33%. 33% only. After that, this inside the macrophage, when this iron and the porphyrin binding, and there ferroportin and binding, and then converting the hemosiderin, and also in ferritin and go into the circulation. So when we look at the causes of iron deficiency anemia, there is an intake iron. If there is a decrease intake, like there is no meat product, so decrease iron intake, so that leads to iron deficiency. If the absorption is decreased, if here is the use of the tannate, carbonate and oxalate, phosphate and other things, or there is a blocker of the this divalent metal transporter, that lead to the also iron deficiency. If there is a decrease of the this transporter, so there is a decrease absorption of the iron. Also there is a demand of iron. If there is a more RBC synthesis occurring going on, and there is no iron in the circulation or in the storage form, So there is also decrease, there is a iron deficiency anemia. If there is an increased loss of the iron, like menorrhea, bleeding, GI bleeding, that lead to also the iron deficiency anemia. This is all regarding the iron deficiency anemia. And when we look the labs of iron deficiency anemia, so in the iron deficiency anemia, most commonly is the nutritional disorder, and this is like when you look, there is the labs of the ferritin is decreased, total iron binding capacity is transferrin is increased, and other all are decreased. Serum iron decrease, and there is a rate distribution of it also increase, and free protoporphyria is increased, saturation is decreased. These are the some lab value. And there is also there is a Palmer-Vinson syndrome. Palmer-Vinson syndrome. Palmer-Vinson syndrome. Palmer-Vinson syndrome is there is a deficiency of iron. Anemia. There is a esophageal wave, esophageal or atrophic glossitis. It occur in the like in the when you look the esophagus, in the esophagus there is a wave formation, and also there is a atrophic glossitis due to deficiency of iron, and also there is a deficiency of iron. Deficiency of iron due to lead to the deficiency of iron deficiency anemia. This is regarding the iron deficiency anemia. Now we are moving also the like there is anaplastic anemia, bone marrow, and also failure of pancytopenia. So when we look the like pluripotent stem cell, when we look there is a stem cell, there is a common lymphoid stem cell and common myeloid stem cell. Common lymphoid stem cell synthesis is in the mature level of NK cell, B cell, T cell. But when we look at the common myeloid stem cell, it synthesis like RBC platelets, basophil, neutrophil, monocyte, and eosinophil. These are the granulopenia and neutropenia. If there is a decrease in this leads to the neutropenia or the granulopenia. But if there is a decrease in all these WBC, so lead to the decrease in WBC, leukopenia. And if only the RBC is absent, so RBC absent, there is a pure red alopecia. Aplasia. So pure red aplasia. There is a pure red aplasia. If there is a decrease in the like RBC, platelets, and if there is a decrease in RBC, anemia. If there is a decrease in the platelets, there is thrombocytopenia. If there is a decrease of the like iron, RBC, platelets, basophil, neutrophil, monocyte, and eosinophil. That's all are known as the pancytopenia. All are decreased, like anemia, thrombocytopenia, and also leukopenia. If three are coming together, that is known as pancytopenia. And when there is anemia, there is a progressive weakness or the pallor dyspnea. And there is like if there is RBC is decreased, so there is also reticulopenia. So there is RBC decrease, normocyte is normochronic. Regarding folic acid, when we look at the folic acid, vitamin B12, vitamin cobalamin, animal products is go in, and also there is a carbon protein in the saliva. There is a carbon protein and folic acid, green leafy and vegetable citrus fruit of 15 to 100 microgram per day. There is a vitamin B12 in animal products, so it go inside the stomach. There is a like parietal cell and chief cell. Parietal cell secrete the intrinsic factor, and chief cell secrete the pepsinogen, and in the presence of NCL. Parietal cell also produce the NCL in the presence of NCL, pepsinogen converted into pepsin, and it degrade the protein of the binded with vitamin B12, and this vitamin B12 is binding with the intrinsic factor, and R binder is lost. Here initially there is this R binder with the vitamin B12, and it should go inside the duodenum, and when you go into duodenum there is pancreatic juice degrade the R binder, and the R binder degrade the intensive factor bind with the vitamin B12. This vitamin B12 and binding with the intensive factor go, and there is a receptor for the cobulin or intensive factor receptor, that from that receptor iron come into the plasma, and when they come into the plasma there is a transcobalamin to this is a portal vein, and it's lead to the iron leave to the portal. There is a classification of anemia, like when you look the anemia. So when globin There is hemoglobin. Hemoglobin is a compound. Hemoglobin is the composition of globin, hem, and globin. The hem is formed from the iron and also porphyrin. But globin is the protein alpha and beta. If there is deficiency of the globin alpha and beta, the alpha thalassemia or beta thalassemia, known as alpha thalassemia. There is thalassemia, most common deficiency of the globin chain, so it is known as alpha thalassemia and beta thalassemia. Also, one important profile. If there is decrease in the iron, known as iron deficiency anemia. If decrease in the protoporphyrin, known as sideroblastic anemia. And where there is a decrease of this alpha and beta, we have discussed. So after iron deficiency anemia, we also discussed the laboratory finding and Pathologic syndrome. And regarding the iron deficiency, there is peptic ulcer disease, breast disease, breastfeeding, and the colon cancer polypolypsis. After that, folic acid, we have also discussed folic acid. So regarding the chronic anemia, in the chronic anemia of patient, there is autoimmune disorder or chronic inflammation or the cancer. This secretes the hepcidin. Hepcidin secretes the hepcidin inhibit the erythropoietin production. Hepcidin inhibits the erythropoietin production, and there is also inhibiting the decrease in the that will decrease in iron, decrease iron leads to iron deficiency anemia. When we look at the laboratory, there is a ferritin increase at TIBC, so decrease iron salt, decrease iron salt. There is salt in the sideroblastic anemia, protoporphyrin, hemoglobin, microcytic anemia. So HL dehydratase, vitamin B6, B6, vitamin B7, information of proper HL synthesis deficiency, HL reduction, lead poison, HL reduction, porochelate poison, labs. When you look at the cytoplastic anemia, there is a fat increase, transparent increase, serum iron decrease, saturation percentage increase.